Great talk, Sarah. Be difficult to follow. Um, Fortunately, we're going to be exiting the Kaplan-Meier curve portion of the talk and into more of a data-free zone. I do some consulting and speaking for a couple of companies that are in the area, but I don't think I have any, I don't feel conflicted. The learning objectives today, we're basically going to go through a typical patient experience who's coming in with a incidental lung nodule. We'll walk through the whole process of them kind of meeting us in clinic and then going on to diagnostics and the options for diagnostics for them. So our goal as an interventional pulmonologist or bronchoscopist is to avoid a non-diagnostic bronchoscopy and to avoid needing repeat bronchoscopy. We don't like repeat customers. We want to get you on to your care and to your treatment as quickly and as efficiently as we can. So this is a patient. She's a 58-year-old former smoker. She's COPD. She came in for chest pain and got a CTPE protocol, and it showed this 11-millimeter nodule in the left lower lobe. She was referred to the nodule clinic for follow-up. So when these patients come in, we do essentially we do a pre-test prediction of lung cancer potential in their nodule. We try to determine the next best steps for them. So we'll do a show of hands here. Which of the following is true for the nodule? Because the pretest probability for lung cancer in this patient is around 11% per the Barak model, a follow-up CT in 1 year is most appropriate. The yield for CT-guided transthoracic needle aspiration, TTNA, is around 95%. The yield for navigational bronchoscopy is approximately 70%. The risk of pneumothorax is higher with TTNA compared to bronchoscopy, or ultra-thin bronchoscopy with radial ultrasound is significantly better than conventional bronchoscopy. Anybody want to take a stab? Four. I heard some fours. You're correct. Very good. So you essentially have two options for minimally invasive biopsy approach with peripheral lung nodules. Transthoracic needle aspiration. This is historically kind of the gold standard approach for lung nodules. The pooled sensitivity in case series is around 90%. The lesions that are in these studies are obviously selected by the people performing the procedure. These are peripheral lesions, close to the chest wall. They're accessible via this modality. The downside, around 15% pneumothorax rate, up to 25% in some of the case series in the literature, and 1% clinically significant hemorrhage. Generally, a interventional radiologist will not go after multiple lung nodules in the same setting due to the high risk of complication, and surgical mediastinal staging is not possible during the same procedure. Bronchoscopy, non-guided, much poorer diagnostic yield, around 34% for lesions less than 2 centimeters, and up to 63% in lesions greater than 2 centimeters. So much lower accuracy. However, the pneumothorax rate around 1 to 2%, and clinically significant bleeding is less than 1%. We are able to go after multiple lesions in the same setting, and we can also do concurrent surgical mediastinal staging of the lymph nodes. The data that I'm showing you here, this is old non-guided bronchoscopy, and there is one prospect. The outcomes for IR guided biopsies versus navigational bronchoscopy. The data of that is actually being presented on Monday at ATS. I'll give you guys a little sneak peek. I can't give you too much, but it's good for me. My job, and we'll go on with their case. So our patient was interested in bronchoscopy, so we got her scheduled. The first portion of our procedure is an airway inspection. And essentially we do Then flexible camera. Generally, these patients are intubated for the procedure, and we do a thorough airway inspection of all the segmental bronchi that we can see. There are 23 levels of divisions in the airways. So trying to find your way to that nodule without some sort of guidance is extraordinarily difficult. I'm going to walk you through an awake bronchoscopy now, so you guys can kind of see what we see when we do these procedures for our patients. This is essentially the level of the vocal cords looking at the subglottic area. The L's that you see on your screen, this is areas that we would topicalize with lidocaine, and there's some anatomy labeled here for you. I'm going to kind of go through this quickly. Trachea, aortic arch, this is the carina with your right and left main stem. This is the right main stem looking at the right upper lobe, RC1, bronchus intermedius. This is going down into the bronchus intermedius. We have, right upper lobe. There's a trifurcation here. They call this the Mercedes-Benz sign. This is the distal bronchus intermedius with your right middle lobe and your right lower lobe. Medial lateral. And then you have MALP, medial anterolateral basilar segments going down to the left. Left main stem is much longer. This is the first carina you see on the left is actually called LC2, and then above that is LC1. You have left upper lobe superior division, lingula, and there's segmental bronchuses and all these. So it's easy to get lost, and everything kind of looks the same. And occasionally we find surprises during the process of doing our airway inspection. So these are just a couple examples of patients we actually have had in the last few weeks of endobronchial tumors. So after your airway inspection, we move on to, depending on your clinical suspicion for nodal metastasis, we'll move on to endobronchial ultrasound and lymph node sampling. This portion of the procedure is very safe. Risks of bleeding are less than 1%. Risk of pneumothorax, less than 1%. The advantage of thorough mediastinal staging is even in patients who have clinical stage 1 disease, there's up to 5 to 10% of occult nodal metastasis. So even though radiographically there may be no enlarged lymph nodes, very thorough EBUS mediastinal staging is really standard of care now and should be done for all patients. For the staging, N0, obviously no regional lymph node metastasis. N1, so if in the case of our patient, she had a left lower lobe. So these lobar and hilar lymph nodes, those would be considered N1 metastasis. Your mediastinal, so 4L and 7 would be N2. And then the contralateral side, so 4R, any of the hilar and lobar, interlobar lymph nodes on the right side, those would be N3s, as well as your supraclaviculars. And supraclavicular lymph nodes is a great thing to examine for your patients. It can save them a trip to a general anesthetic and invasive procedure. If you can find one in clinic, it's a very easy needle biopsy. We do it 5-10 minutes. They leave the same day, and they can have diagnosis and staging extremely quickly. I'm not going to go through this classification. You guys are all very familiar with this. I will show you a little bit of what the anatomy looks like here with EBUS. So these are all the locations of the lymph nodes. Those are the kind of more commonly talked about lymph node stations when we're in our tumor board discussions. This is what they look like on CT scan. So the right lower paratracheal in blue, station 4R. And then on the left lower paratracheal, you can see just below the arch of the aorta is a 4L. These are all accessible by EBUS, as well as the subcarinal and paraesophageal stations. The EBUS scope can just be advanced into the esophagus at the end of the procedure, and we can sample these paraesophageal stations as well. So we can do very, very thorough lymph node assessment with the EBUS scope. As interventional pulmonologist, your probably most powerful tool is your EBUS scope. This is a radiographic representation of a very enlarged subcarinal station, station 7. These are the paraesophageal stations here. You can see just, it's very faint, but in kind of a purplish brown there along the side, right side of the esophagus. So what's the best way to do mediastinal staging? There's PETs, there's CTs, there's mediastinoscopy, VATs, and the different varieties of needle biopsies. So which one would you recommend for your patient? This is a very frequently referenced study looking at 153 operative candidates who had an EBUS, TBNA, followed by mediastinoscopy. And then if they were both negative, they went on to surgery. The sensitivity, the negative predictive value for EBUS and mediastinoscopy were not different. So you don't need to send these patients for mediastinoscopy. EBUS is more than sufficient to get you appropriate staging. This is another case series with 102 potentially resectable patients who had CT scans, PET scans, and then went under EBUS, TBNA. And you can see that the sensitivity and specificity of CT scan and PET scan is fairly poor. These patients, whenever possible, EBUS mediastinal assessment is recommended with a positive predictive value of 100 and negative predictive value of 97.4. So this is a very good test when you actually get a biopsy of the specimen. These are the areas that we can access with EBUS. Basically everything that the scope can reach, including intra-abdominal structures, again, by advancing it through the esophagus. We can do left adrenal biopsies, which again allows for very rapid diagnosis and staging for these patients. The EBUS scope mechanically, its outer diameter is about 7 millimeters. The forward-facing camera is at a 30-degree angle, and the needle kind of comes out of that working channel where the ultrasound is pointed. It's got a latex balloon on it that you inflate with saline, and that allows you to get good effacement against the bronchial walls. So you have real-time needle into lesion guidance. It's like X-ray vision, and it's again, very safe, very well tolerated, and very accurate. So anybody have an idea what the most common complication of EBUS could be? Broken scope. We break the scopes a lot, and it's frustrating, but it is fun to blame the fellows when that happens. But it's a very, very safe procedure, and complications are rare. So we're going to go on to advanced peripheral bronchoscopy. This is the more cutting edge kind of frontier of interventional pulmonology. Traditionally, interventional pulmonologists had to learn all the subsegmental and divisions of the lung, and it was extremely difficult to get good samples of peripheral nodules. Again, there's 23 divisions, and making all those turns correctly to get to your target is a very challenging task. There are several different platforms. There's robotic guided bronchoscopy, some of which integrate EMN, which is electromagnetic navigational bronchoscopy. The way that electromagnetic navigational bronchoscopy works is essentially there is a electromagnetic field generator underneath the patient that then there's 3 transducers that are placed on their chest. We gate their pre-procedural CT scan to the patient. So as we move a little probe that's detected by these 3 sensors in the field, we can see where it is on the CT scan. So this is like how if you go on Google Maps and you look at your location on the street, you're being triangulated by cell phone towers. This is miniaturized, scaled down for the chest. And instead of streets, we have their CT scan. So this allows us to very precisely guide our catheters essentially out to the location of the nodule and get biopsies. But there's a big problem with this, which is the location of the nodule changes from the pre-procedural CT scan to the location during the procedure. This is due to atelectasis, patient position. When you have a patient go in for a CT scan, usually they're at full inspiration, their arms are up over their head. When they're in the procedure room, they may have a neuromuscular blockade, they're fully sedated, they're on positive pressure, their arms at their side, atelectasis quickly occurs, especially with patients with abdominal obesity. So the location of the nodule digitally, based off the pre-procedure CT scan, can be very different than the location of the nodule in the procedure. Virtual bronchoscopy is essentially a planning platform that allows us to drive through the airways ahead of time. This is a pre-procedural planning process that allows you to drive through and pick the airways to get to your target. It's kind of a nice graphic. I'll let you guys watch for a moment. This is a lesion in the left lower lobe, picks out your airway, and then we preview it. And this is basically showing you the pathway that you'll need to take to get to your target. So once you're within the range of the target, we have that issue of CT body divergence. The location of the lesion on the pre-procedure CT scan is not the location of the lesion during the procedure. So in order to try to avoid missing your target, it's really good to have intraoperative imaging technologies to help you find it. There's integration of digital tomosynthesis with EMN, which allows you to find previously invisible lesions on your 2D fluoroscopy during the procedure. Essentially, you do a sweep of the chest, 50-degree rotation with a C-arm, just a standard conventional C-arm, and you get these high-resolution images that really highlight the anatomy within. And you can update your target, this little green ball, as to where you want to do your biopsies. So this is a way to adjust for the CT body divergence during the procedure. This is a study out of Vanderbilt that showed the improved diagnostic yield with the integration of digital tomosynthesis to EMN bronchoscopy. So these were lesions that were generally less than 2 centimeters in size. And you see the historical around 54% diagnostic yield going up to 80%. And this is a follow-up study that looks at the diagnostic yield for a larger number of nodules, 363 nodules. You'll see the literature around diagnostic yield is quite poorly defined. One is we don't even know how to define a diagnostic yield, especially for things that are inflammatory without using 2 years of follow-up. So a lot of the literature is messy. For example, if you have a disease prevalence of 10% in your patients, so 90% of them don't have cancer, and you follow them up after your biopsies and you missed every single nodule, your negative, your accuracy was 90% because by the inverse of your disease prevalence becomes your de facto accuracy. So it's a mess. We need good prospective randomized controlled trials looking at diagnostic yield to actually know which modalities are helpful for patients. A little bit better intraoperative imaging we have is integration of cone beam CT. This is just doing a CT scan during the procedure. There's more radiation involved with this. It's more expensive, but you get very excellent intraoperative imaging. These are some examples of cone beam CT scans. You can see this is a 10-millimeter nodule. Looks like out in the lingula and they have a tool and lesion, which is when you can see the tool inside the lesion in 3 planes with the CT scan. You would think having a tool and lesion would be 100% diagnostic. It's still not. So it's very complicated. There's also histologic limitations, especially with things that are really low grade or things that are inflammatory and difficult for pathologists to determine exactly what it is. Radial ultrasound is another great tool we use a lot, especially if you don't have a digital tomosynthesis or cone beam system. This allows you to kind of hunt and peck through the airways to try to find the nodule. These are 4 different views that you can see when you're using your radial ultrasound. So it's a very thin ultrasound probe that goes out through our working channels and it spins around. And so if you put it directly inside of your nodule, you get an image like A. That's called a concentric view. B, where the nodule is just to the lateral side of the radial probe, that's an eccentric. C, we call that a blizzard or a snowstorm. We see that with ground glass nodules. And D is no view at all. So you're not likely to, and the better the view, the better the odds ratio of you getting a diagnostic sample. So I used to use this slide, and for other lectures, I used to say the robots are coming, but the robots are here. They're here. There's 3 platforms for them. There's Ion type, there's typo, it's Monarch and NOAA. The diagnostic yield for these technologies, again, you need to interpret these numbers with the same caveat of what I was saying before is these are case series with highly selected patients, and the math is spurious. Up to 97%. You know, they have 110% diagnostic yield. And some of these things, it's a little bit hard to believe, but that's what's in the literature. So Monarch uses airway recognition as well as electromagnetic navigation. They use a little like Xbox-like joystick. We have a couple of examples of what their platform interface looks like. Ion, this is another robotic. It uses a shape sensing technology. Essentially, it is able to tell the orientation and configuration of the catheter in the patient, and I'll let you know that you're on the correct pathway to the lesion. This is, again, some photos of the interface. It has a joystick kind of with a scroll wheel and like a flight simulator. So the decision to pursue transthoracic needle aspiration versus bronchoscopy, hopefully we'll change this slide on Monday, is largely based on local expertise. So if you have really good interventional pulmonologists, these nodules typically go to them for management. If you don't, they go to IR or whomever your biopsy specialist of your region is to get tissue. There is no high quality published data comparing the modalities to date, and that will change very, very shortly. So Veritas study is comparing electromagnetic navigational bronchoscopy with digital tomosynthesis to transthoracic needle aspiration with CT guidance. The patients, it's a non-inferiority trial. They enrolled 258 patients. The patient selections are solitary pulmonary nodules in the outer third of the chest. These are the nodules that historically were not things that we would absolutely recommend mediastinal staging. So you have a central nodule, you have a mass, mediastinal staging as part of standard of care. So those patients should not be referred for a needle biopsy because they need to EBUS anyways. So these are peripheral small nodules. These are kind of what we would think of as the lesions of choice for an IR specialist. All the imaging was centrally reviewed by interventional pulmonologist and interventional radiologist, and then they were randomized to one of the 2 modalities, and they would go get their biopsy by them. Again, the data is being presented. It's a non-inferiority trial. The primary endpoint of diagnostic yield, there was no difference in the diagnostic yield. So our bronchoscopists are just as good as the IR guys, and the complication rates are considerably lower, which is also shown in the trial. So if you have a nodule, again, I'm biased, but now there's actual data to support my bias. Refer them to interventional pulmonologists, nodule center of excellence, and we'll try to get the diagnosis in the quickest, safest possible way, as well as providing concurrent mediastinal staging. I think that is my last slide. Oh, the patient underwent a bronchoscopy. Back to our patient. It was a non-small cell lung cancer. Lymph nodes were negative, and they went on to surgical resection. She's still disease-free and follows with us in clinic. She's about 4 years out now, so she's doing great.
So, how specialized or how many of you are there in this because we're out in Naperville and we do EBUS, we are in radiology, we work with the interventionists to get the, you know, the biopsies themselves, you know.
The number of interventional pulmonologists in the country is probably close to 500 now. They're training, you know, 30 to 40 a year. We're actually just got accredited to start a fellowship program here at Rush, so that's exciting. We'll be turning out more of us. There is a paucity of them in the nation, certainly. You know, we find 1.6 million lung nodules a year. The vast majority of them are benign, but for these indeterminate nodules that need tissue diagnosis to determine appropriate, you know, treatment, bronchoscopy for those, you know, patients who can tolerate it is probably the better option for them. So we're happy to help, send them our way. Give us a call. We'll see them.
Somebody out of Copley.
We have someone out of Copley now too. There's more of us every year. They're growing rapidly. Any other questions?